Thank you so much for checking out our presentation today. We're really excited to be sharing our study on quantifying the value of knowing, measuring community preferences for genomic testing in rare diseases. This has been a very collaborative project with a fabulous team of researchers, including Dr. Simon Fifer, Associate Professor Sarah Norris, Nicole Millis, Dr. Jack Nunn, Gillian Mason, myself, Dr. Falak Helwani, and Professor Deborah Marshall. As you can see from the different titles and affiliations, we wear a number of different hats within the research team and come from different areas of expertise. So it's great to all be working on this study together. It's important to note that 3 of our research team members have lived experience with genetic rare diseases, which makes their form of expertise particularly important as a part of this project. Genomic testing can have life-changing impacts for people impacted by rare diseases. However, there is a lack of evidence around how people make decisions related to genomic testing and how they value different types of benefits. So this includes clinical benefits, diagnostic benefits, research benefits, and personal benefits. Now, personal benefits refer to things like the inherent value of information, which can be impactful for a person and their family, even if it's not tied to direct medical outcomes. This is commonly referred to as the value of knowing. All these benefits can be further broken down into health benefits and non-health benefits. These different types of benefits can make it difficult for HTA bodies to assess the overall value of genomic testing. And this has been acknowledged by the Medical Services Advisory Committee in Australia. So with that background in mind, our study aims to address this evidence gap by measuring the overall value that the rare disease community places on different types of genomic testing, including the value of knowing. And we hope that this information will be used to inform public funding decisions made by HTA bodies. The key research questions to answer are: how do patients and carers value the health and non-health benefits of genomic testing? What preferences do patients and carers have about data sharing and associated risk-benefit trade-offs? And how do characteristics influence preferences, such as disease background and other demographic factors? So this study, as I said, has been very collaborative. We've taken a co-design approach to the study, which is summarized in this graphic here. We began with a rapid review of literature and instrument development with the whole research team, including multiple rounds of review and feedback. Once we had a draft instrument developed, we had a community consultation hosted by Rare Voices Australia, where there was 18 patient group leaders from different rare disease organizations. We then did cognitive interview testing with the final version of the survey, where patient group leaders completed the survey under our observation and talked through what they were thinking as they were going through the survey. We are now have just completed the pilot phase of the project and have launched for broader data collection.
Thanks, Maya. We're now just going to talk about the methodology that we used in this experiment. So particularly, you can see at the top, it's a discrete choice experiment, often called the DCE, to look at the community preferences. I'll just explain briefly what a DCE is. So it's actually looking at presenting people with scenarios where they make choices. And these scenarios are broken up by things called alternatives. In this particular basic scenario, you can see it's an A and B comparison. That's what we call a generic experiment. These alternatives are broken up by attributes or features of a particular treatment, and the varying attribute levels, which describe the particular feature. So in this case, you can see administration has an oral versus an injection, frequency, daily versus monthly, and cost 30 versus 35 per month. What we do in these experiments, we ask people to make choices. So compare the options, understand what's important to them, and make a choice. And by repeating this scenario where we change the levels, we can actually observe what's important to people without having to ask them explicitly. In our experiment, we actually broke it up into two different types of two different experiments. DC1, we're going to call that one that you can see on the screen now, and DC2, which I'll show you in a moment. DC1 is looking at particularly benefits versus other risks or costs. So you can see here we have the diagnostic benefits, clinical benefits, chance of personal benefits, links to research, wait time, and out-of-pocket costs. And you can see here we're asking people to make a choice between A and B, so a test A and B, or they can actually choose the neither option, which is down on the bottom left. You can pause here if you want to look at the descriptions of the attributes and levels in more detail, but briefly we had chances ranging from 70% down to less than 10 for diagnostic, clinical, and personal benefits. We then had links to research, which is binary yes, no, wait times from no wait to 12 months, and out-of-pocket costs ranging from $50 to $1,500 in Australian dollars. DC2 is focusing more on the administration side of things. So you can see here we still have two attributes down the bottom, wait time and out-of-pocket costs, that are consistent with DC1. But we have changed the other features of the experiment. So you can see at the top, we have secondary findings shared with you, whether findings are shared with researchers, whether findings are shared with life insurance companies, who stores your data, where the data is stored, and then down the bottom, wait time and costs. Once again, pause here if you want to look at this in more detail, but this is describing the attributes and levels. And you can see here that the levels are more qualitative or categorical, and we did provide descriptions to people as they were going through the experiment. Results, I'll just hand over to Maya.
So here's just a quick snapshot of the study sample based on early data from the pilot phase. You can see that at this stage, the sample is relatively small. However, it's still quite a diverse sample, which reflects the diversity of the rare disease community. You can see that most participants were female. Mean age of participants was 48 years old, and everyone had to be residing in Australia in order to partake in the survey. We had about even representation between people living with genetic rare diseases themselves and caring or having cared for someone with a genetic rare disease in the past. We included bereaved carers in this project, as that was feedback we received during our community consultation, where people who were bereaved carers felt that they wanted the opportunity to share their perspectives as well. The DCEs were framed a bit differently for these individuals, but still have the same attributes and levels. You can see the income distribution there. And in terms of disease background, 36% were living or caring for someone with a rare cancer, and 49%, just under half of those who did not have cancer, were living or caring for someone with a progressive disease. Importantly, less than 30% were receiving treatment to treat the underlying root cause of the disease and were instead receiving symptom management or monitoring only. We asked participants about previous experience with genomic testing and found that just over half had undertaken a genomic test. Importantly, 30%, just under that, had been recommended for genomic testing by their doctor, but had not undergone a genomic test. The main reason for this, the main barrier, was cost, which illustrates the importance of research which can help inform decisions about public funding for genomic tests in the future.
We're now going to look at the results of DC1 and DC2, which we showed earlier on. You can see here in this particular slide, we have the model parameter estimates graph down the bottom, which just show the magnitude and the direction of how these parameters move between the levels. We use those parameters to actually work out attribute importance, which is shown up the top. And that's just a bar that shows you out of 100, what was 100% that is, what was driving people's choices in DC1, which remember was the benefit versus cost and risk experiment. So you can see up the top two things that were driving people in DC1 were diagnostic benefits and clinical benefits. They're roughly equal in terms of their importance. Then we have chance of personal benefits and out-of-pocket costs, once again, roughly equal in the middle. And then links to research and wait time as sort of less important. It's still important, but less important relative to the other things that were compared in the experiment. We asked people then to feedback about the why in terms of getting a bit more qualitative information as to how they answered the experiment. You can see at the top, these are linked to the colors in terms of the attribute importance, but you can see at the top, what is going to have the greatest impact is the clinical benefits. That's someone saying why that's important for them when they're making their choices. I'll let you read the other quotes, but it's great to have the qualitative information to back up these quantitative preferences that we're getting through the experiment. We were then able to look at a couple of different scenarios. So with these models, we can actually look at uptake. So whether someone would have a particular type of test or not. And we can compare different scenarios. We've just broken down 2 scenarios here for you to have a look at from DC1. The first one is looking at where you can see we have the diagnostic and the clinical benefits as low, and the other and personal benefits as high, trying to see how people interact and trade off between them. And you can see even when there's a low benefit of diagnostic or clinical and personal is high, there's still a lot of people who have the test. It's actually around 8 out of 10 people would have that test. That just highlights the importance of the personal benefit to people when they're making decisions about genomic tests. Hypothetical scenario 2 actually then looks at, well, what about if everything was roughly in the middle? So all the benefits were 50%, but then there were these other constraints, like, for example, wait time or costs, which we've set to being the highest. So 12 months for wait time and $1,500 for cost. You can see, despite those having negative impacts on people's choices, there's still a high value on the test. So uptake is really high at around 95%, even with the chance of a benefit at 50% for diagnostic, clinical, and personal. There's so many other scenarios we could do, but we'll wait till the final results to look into those. If we look at the results for DC2, once again, you can see the parameter estimates graph down the bottom to show how they move in which direction between the levels, and they actually generate attribute importance like I described earlier on, which is out of 100%. The key aspects here were whether the secondary findings were shared with you. That's the most important feature. Then out-of-pocket costs, findings shared with life insurers, then wait time, sharing findings with researchers, data storage, and who stores the data, sort of rounding at the bottom 3. But certainly secondary findings shared with you was the most important feature from DC2. Once again, there's a couple of key quotes, but I guess the main takeaway is that people want to be in charge of their own health. So it's this data sovereignty idea in terms of, I want to be in charge of whether I get who gets my secondary findings, who are they shared with. I want that to be my decision, and also sharing with insurers, once again, being very important. So this overarching theme of I want to be in charge of my own health. Once again, we can look at scenario analysis using the model parameters and uptake. If we have things set to only the key attribute there, whether you decide what's shared with you from a secondary findings point of view, but we set the other things to being negative or having a negative impact on your choices. So you can see wait time and costs are the highest in terms of 12 months versus $1,500. You can see even then, there's still nearly half of people would have the test because of this data sovereignty thing. So if they're deciding that's the most important thing, they would still have the test despite these other costs associated with it. In number 2, if we expand on that and we then say, well, you're in charge, but also it's not going to be shared with insurers, that jumps to nearly 3/4 of the sample. So you can see those 2 main factors about you deciding what you do with your data and what gets shared are really driving people's choices with DC2. Once again, we can look at other scenarios as well once we get our final sample. So just to conclude, this was a pilot study. So we are looking to collect more data, and that's what we're doing at this point in time. So we're going broader. We're looking to get over a couple of hundred people working with our partners like Rare Voices Australia. With that, we will actually do the modeling like you've seen. We'll have all the graphs that we've shown you in this previous slide, but we will also develop a dashboard which enables us to look at those interactive scenario analysis. So similar to the things in terms of I showed you with uptake, we'll be able to do that with our whole sample and explore more of these breakdowns. We are also looking to expand to other countries and regions, particularly Canada, given our steering committee team. So we'll be doing that probably towards the end of the year. Once we have our results, we will looking to publish and be transparent and put that in a conference and a journal paper, which is great to be able to get this information out there. But ultimately, you'll see down the bottom, linking to our objectives that we showed at the start, the goal is to use these results in HTA. So use them to guide a framework for measuring value of genomic tests. So thank you very much for your time and listening to this presentation. You can see my email address there if you have any questions, and also Maya's email address, particularly if you wanted to participate in this study. So if you are living or caring for someone with a rare disease in Australia, it'd be great if you could participate. But I email Maya for more information and she can pass on the link. I'd just like to thank our steering committee and our research team, which we displayed, their names are displayed down the bottom. They have been fantastic in guiding us this whole way, and we'll be looking to obviously draw on their expertise as we move forward in collecting our final data. I will just add some additional slides, which I won't talk over, but you can actually pause if you want to see them in more detail. We just have attribute descriptions, so more detail about how we described the particular attributes to people. That's for DC1 previously and DC2 now. And just our model results, which we will be updating. As I said, this is only a pilot. We will be doing more sophisticated modeling, but just so you can see, if you're interested in the parameter estimates and significance, what they were for DC1 and for DC2. Well, I'll leave it there, and please be in contact with us if you would like to find out more details about this study. And thank you to my co-presenter, Maya. Thank you.